TopMedTalk.
This piece was recorded at the beginning of 2020, before COVID-19 restrictions were in place.
Hi, it's Monty Mythen here, Editor-in-Chief of TopMedTalk, coming to you live from the TopMedTalk studios in wonderful Brentford in West London. Joined here today by our Managing Editor, Desiree Chappell, who's also our lead in the USA and our lead anchor in the USA. Desiree, how are you?
I'm great, Monty. Thanks. How are you?
And we're joined by the other professional man in your life, which we picked up in our
My
Christmas
other work
special.
I've been called worse.
Sol Aronson from Duke University Medical Center, one of our partners. Sol, how are you, buddy?
I'm great. Thank you. What a pleasure to be here.
We are joined by a very special guest, somebody who's come in specially today to the studio to join us. That's the wonderful Tom Woodcock, who was working in Southampton clinically, but has relatively recently hung up his whatever you hang up these days.
That's absolutely right, Monty, and thank you for inviting me today.
And it's turned into being a prolific writer and publisher instead of.
Absolutely, and working without pay. That's what happens after you retire, Monty.
We'll get the can out in a second and rattle it round. Yeah. So, Tom, just remind us where you used to work and what you used to do clinically. I know you're working the whole time.
Well, I spent my consultancy time in Southampton General Hospital, and one of the little things that's come up on the Twitter sphere recently is that Southampton was actually an English home of intensive care medicine.
Oh, there we go.
Where Patrick Shackleton came from Winchester's anaesthetic department down to Southampton to establish a university department of anaesthesia, and he wanted an intensive care unit. And he appointed a chap called Doug Pearce. You can find that in the records of the world's first intensive care medicine symposium. There were 4 papers, and Doug's was one of those. And Doug Pearce's intensive care unit was then the model for the St Thomas's intensive care unit a year or two later. Branthwaite and Bradley were appointed at St Thomas's to replicate what was already happening in Southampton. Very pleased to have been at a historic place.
Do you know where Tinker at the Middlesex was in that sort of sequence?
Oh, lovely chap, and I can't tell you, at the moment where he comes into that part of the history.
Because we always claimed we were first, like everyone else does.
I'm sure you did. We're going to have a competition here, aren't we?
But, well, no one looked up the detail to confirm whether that was true or not. But,
no.
Right, here we go. We're going to sound like a true commercial challenge now. I'm holding here a book. You've launched a book.
Very kind of you to mention that.
Fluid Physiology,
Yeah.
a handbook for anaesthesia and critical care practice. And the whole book, and it's a proper kind of off-your-shelf, proper hard-backed sized book with hundreds of pages in it, 260 pages. And it's all about fluid physiology, the fluid moving around your body. Many people would regard that as something that would send them to sleep. I'm excited.
I told him too. I was like, I'm so excited to read this.
I'm excited about reading it. The chapters within it. So notice early on, just by flicking into it, you get into Starling Ernie.
Yes.
Ernest Henry Starling, I think, from University College London.
Absolutely.
One of my colleagues. So obviously, I think it's all about Starling.
I mean, this guy has bragged to me that he is Starling's descendant. Yeah, he's taking a lot of credit. He was giving me all sorts of nonsense about all the the original Starling laboratory data, and
I've heard it all too.
I'd take that with a large pinch of salt.
But you've re-educated us.
He was a memorable chap, and he is justly
You're not going to
celebrated.
tell me he wasn't wrong, was he?
Yeah, and you are absolutely right. In the broadest sense, he wasn't wrong, but he did take us down the wrong channel for a long time.
Okay.
William Hunter said in the 17th century that it's the lymphatics that cleared tissue fluid and returned them to the bloodstream.
There we go.
Starling thought that he was going to go to Europe. I can't remember which lab exactly. It's in the book. Thought he was going to go to Europe to prove that was the case. And in fact, the experiments that he did convinced him the other way. Convinced him that fluid was absorbed from the tissues.
So there's a few.
He made a very fundamental mistake in that experiment, which misled him and has misled the rest of us for the next century and a bit.
So we'll come back to that in a second.
We will.
For the very broader audience who are clinically aware or clinically trained, there's two things we sort of know about Starling, and that's a sort of, the stretch of the fibres in the heart and the volume of the heart and how well it performs.
That's right.
And that so-called Frank-Starling curve, of which they're two different people, Frank and Starling.
Absolutely.
So park that one for a second. But the other one is the sort of Starling
The Starling
forces.
principle, I suppose,
Okay.
and the Starling forces, and
Yes.
you once challenged me quite correctly, the Starling forces are absolutely right. He got all those right.
Hurrah.
Yes, absolutely.
So we get a win-win out of this.
He did. But although he identified those forces, he didn't put them into a mathematical equation. And one blooper that I picked you up on many years ago, you said that Starling gave us the reflection coefficient.
you're quite
He
right.
did not.
Staverman, wasn't it?
That
He
was
corrected it.
half a century after Starling. Yeah.
My wife does that to me the whole time. And the diagram we all remember is sort of a tube, and at one end of the tube there's the balance between pressure and outflow by hydrostatic pressure and what we think of as suck from oncotic pressure.
Yes, absolutely.
So the net flow is out, and at the other end of the vessel the net flow is in.
Yeah.
And that's the bit we're going to get into discussing, because that's not completely true, is it? Don't go into the detail in a second, because Sol Aronson's got a case for you that's going to tease all that out.
I think, thanks, Monty, for that, lateral. I think probably it would be fun to discuss what makes sense and what may have been misleading in the context of a case scenario, one that we're all familiar with. And I'll just set that stage because it's one that I had presented to me not too long ago. Patient who had surgery and went through a routine sort of convalescence post-op, was discharged and came back later, days later, nausea, vomiting, diarrhea, dehydration, to the point where they were prompted to go to the emergency room, and the team appropriately diagnosed dehydration, low volume state, dry mucous membranes, orthostatic hypotension, all that stuff. And they volume resuscitate. We'll just put quotations around that because I know you're going to ask me what we mean by that. To a point where they believed was sufficient, or to what I'll say back to normal state. And this patient who had some myocardial compromised baseline condition became after volume overloaded, and they were having to make up for that which they created by trying to get rid of the excess volume that they iatrogenically put into the patient. And so there are a number of questions that I think should come to mind as we discuss this very common scenario. How much, how fast, what type of fluid constitutes adequate resuscitation? What do we mean by adequate resuscitation? And what goes in, is that necessarily something that we can balance to what comes out? And how many levers do we have as clinicians to really control the what goes in and what goes out sort of formula? So with that case, which I think we're all familiar with, let's talk about the biology and the physiology through the lens of a physiologist. What should one think of and what should one do with respect to the how much, how fast, what kind part of that equation to begin with?
I would even start with what's going on here. Why is it? Why has this patient become dehydrated? He is hypersecreting into his intestinal tract. He's losing it northward and southward. And that means that he no longer has a supply of fluid going into the intestinal mucosa. The intestinal mucosa is fascinating because it's one of the few places where you can sustainedly absorb fluid from the interstitium into the capillaries. It's really important. Diaphragm fenestrated capillaries. Won't get too deep into that technicality. But
It's in the book.
it's in the book.
Check page.
And I call these exceptions.
Right.
And there are a number of exceptions to the rule that you can only filter fluid from plasma to tissue. Right. Yeah. So you have reduced your total body water, you have reduced your plasma volume, you've reduced your extracellular fluid volume, and that's the patient that presents to you. You also have to ask yourself what's been going on to compensate. Most will say what's been going on to compensate is the unstressed volume's been compensated for.
I knew we were going to start talking about stress and
No,
unstressed.
but only very
it's good.
quickly, and
It's
that's
great.
good. The unstressed volume contracts to give you an effective arterial, as we call it, blood volume, arterial blood volume. To protect, so that as we know, these patients can maintain a reasonable vital sign, a reasonable blood pressure, a reasonable heart rate before they actually start to decompensate fast. The other thing that they can do, if the capillary pressure has dropped fast enough during their dehydration, is that they can, although I said to you that absorption doesn't occur, it does occur transiently. And in a human being, that transient reabsorption, that the physiologists call autotransfusion, is up to about 500 mils. And it varies from tissue to tissue how fast that process completes, but averaging 30 minutes in an adult. So your first 30 mils you do get back from the tissues.
Acute and short-lived?
Acute and short-lived, and as you said, one shot.
Right.
Is that why you can donate a unit of blood?
Yeah, absolutely. Yeah. It's one of the reasons you can donate a unit of blood.
Your big picture stuff.
They don't take you down fast enough to reabsorb. No. I think the compensation for donating blood is the stressed volume and increased lymphatic pumping, which is the next thing I was going to come to. A phenomenon that was identified by clinicians in the 60s and 70s and then seems to have just dropped off the radar. That when you become hypovolemic, the sympathetic overdrive starts pumping your lymphatics. That starts moving tissue fluid back to the lymph nodes. Absorption occurs from the lymph nodes of clear fluid. More importantly, perhaps equally importantly, the efferent lymph also starts squirting out. And the recovery from hypovolemia is mostly due to proteinaceous fluid being pumped back into the bloodstream. When you think about it, if I bled you, you would have low proteins during recovery from that hemorrhage. You don't. Your proteins stay high, and they stay high because proteins come back with the water.
What's the capacity of that second tier, if you will, the lymphatic pumping compensatory mechanism? How long is that sustainable? What is the effectiveness of that compensatory process in this patient who we now see in the emergency department by all clinical signs and symptoms is dehydrated?
Sure.
What could someone infer as to the how long and how much was?
Sure. The evidence that I've gleaned in researching this book is very much taken from 20, 30 years ago because we have just stopped looking at it. But it's of a minimum of mill a minute, and I would guess going up to 3 or 4 mils a minute. So that if your patients had several hours, then that there could be quite a lot of compensation that has gone on. And that will be contracting the interstitial fluid space. Now, can I leap ahead quickly to preferred fluid? Because, you're all clinicians.
You can do whatever you want.
Oh, you're very kind. Because what we are looking at in your scenario is not a defect of plasma volume, it's a defect of extracellular fluid volume. And the interstitial fluid has taken a big hit. And so you should be giving back an interstitial fluid, and that's an isotonic salt solution. Now, you can talk about your hamburgers, you can talk about your ringers, you can talk about your Hartmans, you can talk about your plasma lights. I think, guys, that conversation is just distracting you from way, way more important things. And we're not going to talk about chloride today, are we?
Broadly speaking, a salty...
an isotonic salty solution. And there is evidence, again, from small studies and a long time ago, that if you prioritize resuscitating the interstitial fluid space, maybe even prioritize it over in resuscitating the plasma volume, you'll get better outcome results. And there is so much research needs doing in that field. One of my reasons for giving you guys this book, because I'm never going to do this research, is to inspire people to look at what we need to learn about clinical resuscitation from a physiologic basis.
So, Tom, if they're appropriately compensating, he's telling us there's no rush as well. Is that part of it?
I think that's exactly right. That I think it was Sheldon Magda who said what we really want is a machine or a test that tells us when to stop giving fluid, and that's what your patient needed. Your patient needed someone to say stop before you overloaded.
So let's speak to the common knee-jerk reaction, bolus. We're treating somebody who's dry, hypovolemic, let's give them a bolus until something. And
I'm going to caveat that. Yeah. Is this patient now overtly compensating or decompensating?
Which, again, we're creating a hypothetical that we're trying to make a reality. Dry mucous membranes and orthostatic hypotension.
But their mean arterial pressure is acceptable. They're conscious.
They're conscious. Okay. They're oriented.
So we're not into resuscitation mode.
Yeah. Okay, this isn't shock and unconscious. Okay. But clearly, by any standard of our measure,
they're not quite
clinically underloaded with respect to volume.
If you've got an appreciation of how physiology addresses this and how physiology tries to save the organism from that hypovolemic incident, then what you'll do clinically is to try to augment that physiologic recovery process. And that means going forward to augment that recovery process, not going back and trying to go back up the slope that you went down. The old idea of he lost 5 litres, so I have to give him 5 litres is a very dangerous concept. And you want to get that patient into improving. I am really convinced that setting goal of normality, a normal blood pressure, we hemorrhaged these people, we took them back to normal blood pressure. You don't take them back to normal blood pressure. How many patients do you see in your practice who come in with a high blood pressure, and when you discharge them, they don't need their blood pressure tablets for a week or two before their blood pressure starts to go back up again? Having a lower than hypertensive pressure is quite a normal way to recover. And what I think we should be targeting when we give our isotonic salt solutions is a perceptible improvement in the situation, a perceptible rise in the blood pressure, and particularly the diastolic pressure, which when you're hypovolemic is very close to capillary pressure, and perhaps a fall in heart rate in patients who are capable of generating that. There may be something in heart rate variability that we could be investigating here. That's been looked at in the past, and it's a field worth looking at, I'm sure. And although central venous pressure is too difficult to measure and sensitize, it may well be that there's going to be a signal in the venous pressure wave that we could look at and assess and use to guide us. I don't believe there ever will be a single measure, a single machine to tell you this is the stop point. I think there's always going to be clinical judgment involved in this patient is now back on a recovery trajectory, and all I need to do is to support the recovery trajectory. I don't need to push him to get back to normal fast.
So that's a really important point, because I think it really is not the common belief and behavior in that we ascribe to get to normal. If we're not normal, we should get back to normal. And what you're saying, if I may, is just bend the curve of decreasing the slope of diminution. So we allow the patient's own physiology and biology to do their own homeostatic sort of recovery, and normal, getting back to normal, may actually be an overshoot. Yes?
Yeah, achieving normal early on will be artificial normal and pathological normal.
Right.
Well, I guess in this hypothetical patient, we were saying that when they were resuscitated, they over-resuscitated that particular patient, or how do patient comorbidities affect
So
all of this?
The scenario, if I were to paint, was they resuscitated by the temporal need to acutely get back to normal vis-a-vis bolus kind of volume resuscitation. Normal itself then portend too much, and the scenario would continue to say that they were then stuck with having to get rid of the excess volume and how one does that, and I wish to speak to that as well. Before we do, though, I wanted to the point of resuscitation. We're so obsessed with monitoring inputs and outputs. INOs, every ICU tracks that, and we try the best we can to take good histories to determine what the output is to balance that with an input. Thoughts on that?
Go on, you're going to have to help me out with that one.
Fluid balance charts.
Fluid balance charts.
Yeah, absolutely. Yeah. Fluid balance charts in my time were extremely difficult because on the intensive care unit on one side of the corridor, we did them differently to the intensive care unit on the other side of the corridor. Particularly stuff like insensible losses and whether blood was included as a separate fluid or was part of the overall fluid. And I don't know whether you, in wide practice now, have a sort of normal or a standard for fluid balance charts. Fluid balance charts very, very difficult. Weighing the patient would be the one wonderful thing to do. And throughout my career, I was always told it's not possible to weigh a critically ill patient.
Taking the scenario now to the next tier, we, for whatever reason, understood now that normal was too much. The patient couldn't compensate, and they were motivated to get rid of the fluid that they wish in retrospect they would not have given. How easy is that to do? And how logical is that even to think possible?
Just want to frame this for a second, Sol. So they have, for example, by enthusiastic resuscitation ended up 3 litres positive, 5 litres positive? Can you give me a ballpark number that's not unusual?
I would say, without having to quantify that, the patient was orthostatic hypotensive. They're no longer orthostatic hypotensive by that goal threshold of a successful resuscitation being, let's say, they're no longer orthostatic. They gave enough volume to enable that to be the case, but the patient now had a low output syndrome that was unable to compensate with that volume that they gave them.
They got pitting edema and now weights up by kilograms.
And now they're having respiratory difficulties, and their work of breathing is greater, and they're having some signs of excess water, and they want to get rid of it.
So let's, for argument's sake, say that they're 3 litres, 3 kilograms heavier with salt and water in their body that's contributing, we think, to some of the problems.
Right.
What about getting that out, Tom?
Well, first of all, an important point is how it got in there is the fact that your little diagram of fluid being filtered and then absorbed would suggest that you could simply pour in until the you've done enough filtration, and the rest would be absorbed.
Yeah, you can suck it out quickly.
It clearly is not sucked out quickly. It clearly persists. It clearly can only be cleared in your clinical practice by lymphatic activity, by lymphatic pumping. That is the only way to get it out. The plasma volume will be overexpanded in these patients, and you've got to do something about reducing the plasma volume, because that's what's going to kill your patient. And
I'm just going to pause you for a second, Tom. So our observation on intensive care, for example, where a lot of people end up with a lot of salt and water in excess of their baseline, when we put them on an artificial kidney machine, you can't suck all that out in a short period of time. It's a nice idea, but it just does not happen. Is that right? Is that where we are?
I think you're right. You have to take it out fairly carefully or the patient collapses.
Yeah, exactly. But the idea that if you could just suck it back in, you should be able to sort that out in a couple of hours, and you can't, can you?
We don't need to go deep into the physiology to agree that, do we?
It takes by multiple observations, days and or weeks to do it.
It does.
So what's the rate-limiting step, then, that you're about to tell us about?
Well, the rate-limiting step, I reckon, is going to be having an adequate capillary pressure for re-establishing the interstitial fluid balance and keeping it at that level while the balance reoccurs. And one of the things that you'll find in my book, if you take the trouble to read it carefully, is I believe that there is a link between the capillary pressure and what some people call the mean systemic pressure.
Yeah.
Or this Guyton pressure, a pressure which doesn't exist. It's entirely mythical. But the capillary pressure, or more specifically, the pressure of fluid just as it leaves the capillaries and goes into the venules, the collecting venules.
On its way back to the heart.
The venular filling pressure. Yeah, the venular filling pressure is, I reckon, the bit that ties together microcirculation with macrocirculation. And that, I reckon, is, in an ideal world, what we would be targeting to optimise the recovery of our patients.
So, in back to Sol's question, the time taken to get it out.
Right. So we are where we are. Well-intended, good clinicians. We're all familiar with the scenario that I think I just described. What can one expect to happen? And the common, if you will, behavior is to give a diuretic, to enhance, if you will, diuresis and try to regain that sort of equilibrium of balance. What's going on, and why are we missing the mark?
A really important thing to remember is that even if you were an ASA1 athlete with wonderful renal function, you will still take a while to clear that. You will not simply diurese that out. And one of the reasons is that it's in the tissues and it takes a long time to come back. The other, and I think this is an overlooked issue in intensive care medicine, is that almost all your patients are vasopressinemic. They are living in a world where they are retaining sodium, and stopping them retaining sodium would be a very difficult thing to do. Maybe you don't need to stop them retaining sodium. You need to let them get over their vasopressinemic state. And that vasopressinemic state, if you bear it in mind, will make you very cautious about inducing hyponatremia with hypotonic solutions.
So the key takeaway that I've got from all of these discussions is we can push it out quickly.
Push it in quickly.
But in other words, push it out from the vessels into the interstitium quickly.
That's right.
That we can push that hard, and that
fast
goes quickly.
As you like. And if you give a bolus, I mean, we've got data here from Robert Hahn. if you give 100 mils a minute of fluid into a vein, it passes to the tissues at 100 mils a minute.
Depending on the circumstances in which you give it. So you can push it out quickly.
Yes.
But you can't suck it back into the vessels at the same speed.
That is 1 to 5 mils a minute at best.
And most of that is via the lymphatics.
Absolutely.
Into the right side of the system. So right-sided pressures are going to play a part in that.
They do.
And the function of because the lymphatics have got form, function, structure. They're influenced by the sympathetics. Is that right?
You'll find when you read about the lymphology, if you like.
Where do you read that? I'm sorry?
Lymphology. Yes. Lymphology, it's exactly like cardiology. There's preloads, there's contractility, there's rate, there's rhythm, there's valve function. It's lymphology is cardiology.
Chapter 5.
The forgotten organ.
The forgotten organ.
Because we said with our fluid, we had a fluid physiology perioperative quality initiative, which will be out this year.
Yeah.
There's a picture next door we're just looking at. We came away with that with the idea that lymph is the word. We said it's not grease, it's lymph.
Yeah.
It's the unforgotten system. We didn't. You learn much about it, Desiree? We never learned much about it.
No.
Monty, can I answer the question on 2020 most important concepts?
Go for it.
I'm going to lead lymphology on that.
Lymphology.
There you go. Start with your book.
But practically, Tom, that is don't push too much out.
Yeah.
Be a bit more, as we say, physicianally. We tend to be flash bang in anaesthesia, critical care, emergency medicine. But once you've restored an adequate circulation, take the heat out.
Once the patient is perfusing, once everything's on its recovery trajectory, back off.
Take the heat out of it.
Support the recovery trajectory.
And I would say it's not even once you restore normal. What I'm taking from this conversation, Tom, is that you don't want to restore normal. You want to reverse the trend of decrease.
Your end point is an improving patient.
So
pull out of the dive.
Pull out of the dive and let the body do the rest.
Just give the patient
Don't have
the
the
fluid
goal
he
of
needs.
being normal. If you hit normal, you probably overshot.
Yeah.
If it's a healthy patient, you may get away with it. If it's not, you likely won't, and you have to ride the consequences of that because time is going to be limiting as a factor here. That's a materially important and different than most of us would, readily kind of knee-jerk respond to.
Oh, and you can't blow the patient up with a ton of furosemide or Bumex to get it out immediately.
It doesn't fix your air.
Yeah,
it's a slow process. Now, there are pre-recorded conversations with Tom and others on TopMedTalk about this subject area. We'll come back to Tom during the year and do a lot more detailed discussion about this. It looks like an absolutely wonderful book. The little bits I've dipped into so far have been fun.
Oh, Tom, I just wanted to, because we didn't really get into this too much. Tell us why you wrote this book. Like, why were you inclined to do this after you lived a life, clinically, and you've gone into retirement, and you could actually retire and not do it?
You're going to take some credit here, aren't you? Because it was while we were sitting around in North Carolina doing top med talks with Monty and so many other top physicians from both sides of the pond. That I realised that we didn't even agree with one another. We did not have a consensus view on the very basic subjects of fluid physiology, and I needed to write a book. And I think I declared to the audience in B that I needed to write a book. And so I'm proud to bring it to you today to say I've closed that part of the cycle. I've delivered the book.
Excellent. Tom, thank you very much indeed. Now, it's available on all the popular sites.
All the standard online websites, or directly from the publisher, which is Cambridge Scholars Publication.
And you went straight in the top 10, didn't you?
On the first week of publication, it was number 7 in Amazon's top-selling critical care textbooks.
And leave that there. Don't spoil that story.
Let's not spoil that.
Top 10 publication. Now, I want to ask, there's a link here. So we were hearing this morning from my daughter Charlotte, who's at University College London. She got red carded in the library. So she was in a library. Well done, student, for being in a library surrounded by books. And what did she get red carded for, Desiree? Did you hear that bit?
Loitering with an intent to eat a banana.
Yeah, a banana. So she had a banana on her desk and she got red carded. She hadn't eaten it, but she was loitering with intent to eat a banana. So well done, UCL, for that one, calling out on that one. What's the link between Ernest Henry Starling and bananas?
Oh, very good. Yeah.
Oh, wow. I was wondering where you were going with that.
There's a segue that I,
never heard before and won't ever again.
It's in the book.
Starling died of intestinal infection, and so I decided to colourfully call it septic shock.
Yep.
While he was on a cruise going down to the Caribbean. But in those days, cruise boats were not cruise boats. They were you just paid your passage on a banana boat going to and from.
Thank you. Ding, 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 ding.
That's awesome. Hey, Tom, where can we find you on social media? Because I know that's playing big right now for
is
you.
It at Tom Woodcock on Twitter? Is that right?
On the Twitter.
I don't remember.
You're very active on Twitter.
You are
I'm
very
out
active.
there.
I love it.
I'm aggressive, and some people love it and some people hate it. And I count the number of people who blocked me, and I'm proud.
Oh.
You're retired. There's nothing holding you back. And you and a few other people...
You'll discover, Monty, that when you retire, people want you to do all sorts of other things. You'll know Neil Soney, for instance, who allegedly retired a few years ago. Yeah. And he and I can barely find time to go fishing because we're always being asked to do this, that and the other, for which we don't get paid.
He was going to build a wall. Did he build
Was
his
he?
wall?
What, Neil?
Yeah.
Yes, he did build his wall. Magnificent wall. Yeah. And he sits out in
the wall. But
well, the last time I phoned him and asked, he said he was sitting outside on a deck chair admiring his wall.
So he's a man who said he was going to build a wall, and he built one.
Too many references to Twitter and walls. I'm just, getting a little confused about this. Retirement doesn't mean death, for goodness sakes, and, carry on, right?
Oh, I'm at the moment, I'm doing research ethics for the NHS Health Research Ethics Authority.
That's what I like to hear.
And I'm lecturing law and ethics for NHS Wales at the moment. If I can give a little upcoming for the non-consultant career grades of North Wales, will be hearing my words on law and ethics in a week or two's time. And if I can just give a little heads up to a launch date, 4th of Feb, the Association of Anaesthetists, not Great Britain and Ireland anymore, they're rebranded.
Oh, right, sorry. Yeah,
the Association of Anaesthetists will be...
Association of Anaesthetists.
We'll be launching our working party on steroids and perioperative care on the 4th of February.
Excellent.
So
take away from that.
Please, let me not spoil it.
Okay.
This is a working party I started many, many years ago. I can't believe how many years it's gone on for. But the wonderful thing is that André Vercoul, particular credit to him, has delivered a consensus between physicians, patients and anaesthetists on how we should be managing steroids in patients.
Tom, you're wearing retirement very well.
Yeah,
thank you.
Can we TopMedTalk interview the team about that, Andre, etc., in the wake of that?
I expect he would be. Well, like I say, he's established a launch date. Why not talk to him about it?
Brilliant. So, Thomas Woodcock, it'll be in the show notes, Fluid Physiology. Congratulations, Tom. Thank you for all your work. We are now confused at a completely different level.
Well, now we have a resource.
Okay. Thanks very much, everyone.
Thank you very much, everyone.
TopMedTalk.
It's Desiree Chappell here. Just a quick reminder, subscribe to TopMedTalk. We're a daily source of news and conversation focused on perioperative care. We bring you all the latest talk from all the major conferences in the perioperative space. We can also be found on Twitter, Facebook, LinkedIn, Instagram, and we now have a free mailing list with special offers and additional goodies for subscribers. Go check us out at topmedtalk.com. That's www.topmedtalk.com.